Hello, Sudeep Doctor Sahab. Can you hear me? सही त सुने छैन जस्तो सुन्ने होला पेयर गर्नुपर्ने हो भइसक्यो सुनिरहेको थिएँ गइरहेको थिएँ म आज डक्टर बोल्नु भएको छैन बोल्नु त बोल्नु छैन ल प्रिपेयर गरौँ प्रिपेयर Hello, Dr. Sudeep, am I audible, please? I can see you in Zoom. Hello? Hi. Hello? Dr. Sudeep, am I audible, please? I can see you in Zoom. Sorry, he is 25. He is 53 years male. he had history of fall from bicycle 5 years back, and he sustained some injury over his left knee joint, and he visited some local centers, and he was treated as soft tissues injury conservatively. Now he complains of instability. Sorry, he is 25. Okay, he is 53 years old. He had history of. He had some anterior knee pain as well. He has problem with when going upstairs and downstairs movement. So he has some instability and some PCL related symptoms. So on the examination, what we can find is, as we can see, there is some sag, grade 3 sag. This is posterior drawer test, which is positive. And he had quadriceps active test that was also positive, which cannot be demonstrated at present because the patient has been anesthetized. So this is grade 3 sag, no anterior medial. Sorry for technical issue. What? So this is his clinical examination. As you can see, the posterior drawer test is positive, and we can see there is grade Godfrey sign positive, that is grade 3 sag is positive there. And so this is how we can elicit those tests. The quadriceps active test was also positive, but it cannot be elicited because of patient being anesthetized. So we'll shortly start the PCL reconstruction. We'll be taking, maybe we'll be taking graft from peroneus longus as a primary graft, or hamstring. We'll decide during surgery. Okay, thank you so much. Dr. Bhadra? Bhadra?
Yes.
Audible?
Yeah, Vivek.
Audible?
Yes, you are audible.
Okay,
Clear,
okay,
clear.
okay. Thank you so much.
Thank you.
So, dear friends, today, this is our third live surgery for the day, and maybe this will be our last live surgery, where we have already telecasted live, demonstrated live surgery of ACL reconstruction with ACL repair plus augmentation. Then we did shoulder Bankart repair plus remplissage, and finally this is PCL reconstruction. ल अन भयो अनम्युट गरेको त्यो अनम्युट भयो अनम्युट भयो त्यो अनम्युट गर्छु अनम्युट गरेको अनम्युट नै छ Am I audible?
Yes, Vivek.
Okay. So shortly, in very short time, we will be starting our live surgery. So as I have already mentioned, he is 53 years male who sustained injury over his left knee 5 years back. He was managed conservatively for that injury, and gradually he started having pain over anterior knee joint, and then he also complains of instability more so when he goes upstairs and downstairs. So this is his MRI. This is coronal cut, sagittal cut, and axial cut. In coronal cut, what we can see is there is some meniscal problem. The meniscus has, there is partial extrusion of the medial meniscus. Rest, medial and lateral pillars looks okay. Meniscus looks okay. And in sagittal cut, what we can see is there is good ACL shadow in this. You can see there is good ACL shadow, but as it is commonly said, PCL will look normal in chronic MRI in the setting of MRI in chronic setting. But what we can see here is there is some break in PCL shadow over here. So it also says there is some PCL injury. Okay. So in axial cut, there is not much of significant finding is there. So yeah. So let us see some surface marking over here.
Vivek,
I have marked.
Can you show PCL test, please?
PCL test, yes, sir. So, so this is the drawer position. The hip is flexed 45 degree, knee 90 degree, supported with foot rest and side post. So the first clinical inspection we can see that there is very little prominence of the tibial tuberosity. The sag is there, posterior sag because of gravity. and this is posterior drawer test. See, the drawer test is positive, more so in posterior direction. The anterior drawer is negative. The problem with chronic PCL tear is there may be false if you are not careful enough. This can be falsely tested as positive anterior drawer test, but it is in fact the TBI is being pulled from its sag position. That's why it seems a false positive anterior drawer test. In fact, it is posterior drawer test is positive in this case. And if I palpate the medial joint line, I cannot feel the medial joint line. The medial femoral condyle is more prominent than the joint line, so it is grade 3 sag. So clear-cut indication of surgical management in PCL injury. So in this case, we have decided to take hamstring for PCL injury. So let's go and do scopy. Tuniket? Badra, nice question. PCL injury, isolated PCL injury is not so common injury. Usually PCL injury is associated with some form of posterolateral corner injury or some form of other ligamentous injury, but we do see some cases of isolated PCL injury and we have to treat them accordingly. The grade 1 and grade 1 SAG is always conservative. Grade 2 SAG plus minus. If patient is symptomatic, do surgery, otherwise not. You give a trial of conservative management. Grade 3, always surgery. Okay.
Vivek?
Yes, Badra.
Vivek, is SAG sign always present in PCL injury?
Yes, SAG sign is the most important sign, I must say. SAG sign is the most important sign, and it is the grading of SAG sign which gives us decision whether we have to do surgical intervention or not. There are some papers which say that it is the stress test that decides surgery is needed or not, but I think very good way how to decide surgery or not. So this is the surface landmark. This is patella, patellar tendon, femoral condyle, tibial plateau. And one trick in PCL surgery is always make a portal very near to patellar tendon and as high as possible. So I'll be making my first anterolateral portal right below the patella and just lateral to patellar tendon. So I think Vivek, I am visible. Yes.
Vivek, is there any difference between the making a portal in doing ACL or in reconstruction and PCL reconstruction?
Usually there is not much of a difference, but when you do PCL reconstruction, if you remain as high as possible and as medial as possible, medial to patellar tendon as possible, you have that plenty of room to play at the notch area. So it is always good to make your portal high anterolateral and high anteromedial portal. So it makes your surgery very easy.
Okay, thank you.
So I am inside the joint now. So hope I am visible. The inside view, please. So this is inside view. So we are inside the joint, suprapatellar pouch. I'll just give some wash. This is suprapatellar pouch. As we always say, the knee joint extends way above than the normal patellofemoral articulation. See, patellofemoral articulation is right there, but knee joint extends up to here. Arthroscopically, we can see it. In chronic PCL tear, like in this case, one place where we have to look into is the patellofemoral joint, because of sag, what happens is tibia goes back and there will be pressure or there will be friction between the femoral trochlea, femoral condyle, and the patella. So patellofemoral joint inspection is very, very important along with the trochlear inspection.
Vivek?
Yes.
Sometimes it will be a little bit difficult to see the undersurface of the patella. So is there any tips for the beginner how you can see clearly the undersurface of the patella during diagnostic arthroscopy?
Trick is you go into suprapatellar pouch, come back slowly till you find
this part of the little part of the trochlea. Then from here, what you do, you just rotate your scope, and at that, by doing so, I think I don't think there will be any problem viewing the patella. If you still have problem, you can ask your assistant to push patella inferiorly and sideways so that the patella will be visible. I think that is a trick. I think
yes,
I have
thank
answered
you.
your question, Badra. So this is
lateral
gutter.
Thank you.
Lateral gutter. So there are some synovitis, and this is, you can see, this is popliteal hiatus, right? And coming back to suprapatellar pouch again, this is medial gutter. Some plicae, I can see some plicae. I think this is also pathological. I will see where their consistency. If they are firm enough, I will be excising this plicae as well. So this is medial joint, medial compartment. See, the cartilage does not look that good. This is the result of chronicity. You know, if had it been reconstructed or surgically managed earlier, all of these things could have been prevented. So this is the result. So this also must give us the some lesson that those things which has to be managed surgically should be managed earlier. Earlier the better. So this is meniscus. I'll be seeing the meniscus. Okay, meniscus flounce looks okay, but I will need to probe later. This is just a diagnostic round. I'll do some wash. See? And I'm going to posterior medial compartment. There is no ramp here. Just relax, Rohit. Okay, this is ACL, looks okay. I'll be staying in this part, triangular formation formed by ACL, femoral condyle, and lateral meniscus. This is lateral meniscus, looks pristine. That is the popliteus tendon, you can see there. And the femoral condyle, lateral femoral condyle cartilage is pristine. Nothing is there. Okay, let's go back to 90-degree position, drawer position. So this
Vivek,
yes, sir.
We have seen medial meniscus extrusion. So have you confirmed the root tear of the medial meniscus?
Yes, of course we'll do it, sir. I have not probed it. By general inspection, I don't think there is any root tear, but I'll surely inspect with probe. So this is very important finding. See, this is ACL. The ACL is slack. This is floppy ACL sign. As you do the anterior translation of the tibia, like this, what happens? The ACL is tightened. At first vision, you may think that the ACL has been turned, but it is not so. Because of non-functioning PCL, the ACL is slack or ACL is sloppy. And this is the result of the aim of our surgery would be to tense this ACL back to normal. Okay. So we have now confirmed the PCL tear is there. He needs reconstruction. We'll be now harvesting our graft. That will be hamstring. Thank you. Now graft harvest. Yes? Can you come? Okay. Light on, please. So, knife, please.
Can you change to outside view, Vivek, please?
Yes, sir. Yes, sir. We are doing it. So, hamstring harvest has been telecasted live earlier as well, but we'll be doing it again because you do again and again, it will be more better. I think it is a better thing. So this is my landmark is you just palpate over the proximal tibia. You can feel the bump. I can feel that bump. One technique is that one. Second is you just mark this posterior part here at this posterior part of the thigh. There is hamstring tendon. Just come, just extrapolate this line and give an incision, making that point at the center. So this is we give oblique incision as it has been proven by research. Amit sir has also done research on this. which shows SSP and knob injury is less with this type of incision. So we'll be following that. I've given. Yes, yes, please.
Is hamstring your first graft choice in PCL?
Yes,
or
yes, of course, of course.
Okay.
Hamstring is first graft choice. Bleeding. Thoughts forceps. Stop. Cautery, please. So as I always say, never be scared or never get frustrated with this bleeding. If you get this bleeding when you harvesting this graft, be happy, you are in right place. Just do coagulation. Usually there are two bleeders that you will encounter during this harvest. Be happy. I am happy because I am in right place, I think. So knife, please, again. So you have to dissect the deeper tissue. Cautery. Okay. Continue dissecting deeper till you find the aponeurosis of the. Till you find this aponeurosis, that is the sartorial fascia aponeurosis. Okay. May I get the artery with the gauze? Artery with the gauze. Thank you. I hope the vision is clear. Badra?
It's clear. It's clear.
Amazing.
Thank you. Thank you.
So for all the listeners who are there listening and watching this beautiful video, live demonstration, we have just recently established this live telecast system.
So this is what I was telling. So this glistening fascia, up to this, you have to dissect. So then what you do is you have to fill. I think there is some movement. This is bump, double bump of two tendons, the semiti and gracilis. You have to fill it. Then grasp that thing with the help of the Ellis tissue forceps. I must say the good one. Otherwise, you will be frustrated in this step. So why we do it is just below this fascia, just below this pes tendons, there is MCL. Always to prevent MCL, you just have to lift and give a cut over this. You'll get this type of opening. See, I think that is visible. The lower glistening tissue here is the MCL. So if you lift it, the MCL injury is prevented. Otherwise, you will be injuring this. So this is pre-sartorial fascia. I will be cutting it like this. I will be dissecting here right up to the scene of tibia, right, like this. Then, knife, please. Okay, this is horizontal part of our incision. Then we will give the vertical incision. I hope I am visible.
Vivek?
Yes, yes, please.
So what may be the difficulties will you find at this point while during harvesting the graft?
Badra.
Yes.
Badra, I didn't get you. Please, can you come in again?
So any complications or any difficulties we will get during this position, I mean, this procedure?
Yes, yes. First thing, it may be very difficult to get those tendons right. You may be picking up only one tendon. Okay. When you give the bite with the, when you incise with your 15 number blade, you may be cutting that thing, the MCL. So here you can see, this is the face, this is the medial raphe. Above here is, this is the gracilis tendon, and below this median raphe will be our semiti. Is it? Wait. So this is semity. It's our habit that we always take semity first. So I'm doing it. Otherwise, in PCL reconstruction, we need to take both. It's a routine. Organ dago, right? So that is PCL. That is semity, and this is hamstring. Hamstring line dago, please. This is gracilis. Okay, that's it. Artery. So now it is more clear. See, these are the two tendons. The lower end is semity, upper one is gracilis. By their caliber as well, you can differentiate both of these tendons, and we'll be harvesting both. First thing first, the semity. Retractor, please. So semity is very special tendon, you know. If you have to be very careful with semity. Gracilis, it is not so much common because semity is attached with vincula at 3 or 4 vinculas from medial gastroc. And what happens is, sorry, not medial gastroc, it is from semimembranosus. And if you do not release all those vincula, you will be getting smaller size semity graft. And another thing, if you miss this semity graft, it will retract right deep into that thing, into the space, and it will be very difficult to retrace that tendon. So you have to be very careful holding this tendon because it is very, very difficult if it goes away. So I am releasing the vinculus attachment very carefully and meticulously, because if you do not release this is the cause of the early premature amputation or short diameter graft. Great. Thread, please, Ithibon. Mr. Yogi. Okay, now this is whip stitch we are putting. Please stop me if you have any questions. Usually I take 5 bites, then come back. Badra, you were asking me whether hamstring is my primary graft for PCL or not,
yes.
right?
Yes.
So in case of multi-ligament injury, PCL is usually reconstructed with peroneus, but in case of isolated PCL, hamstring is usually our first choice. So I will make sure that everything is released.
Okay. Is there any reason for that, Vivek?
Yes.
Hamstring.
For when we, in the situation of multi-ligament, we usually do ACL with hamstring tendon. That's why we need peroneus. Otherwise, in case of isolated, I'm okay with hamstring tendon. That's why. So if it is completely released, usually it crosses the midline of the scene of tibia. So I think that is completely released. I'm using close-ended stripper going in. So usually there is hiatus. You will get blocked. You will get some pause over there. Then what you do is you just go inside like this and do just gentle tuck. The hamstring will be harvested. See, nice hamstring, nice semity. So second one, what we'll be harvesting is right angle, please. The gracilis tendon. So this is gracilis. Ellis, please. Usually, gracilis is usually very shorter and lower in caliber than semi-T. That is how we recognize them. So we'll apply Whipstis in this tendon as well. So Bhadra, what is your primary graft for isolated PCL?
Generally, I prefer peroneus longus.
Any reason?
No any specific reason, but I think it's stronger and longer also.
Okay. 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 Ellis, please. So this is one of the complications. You know, you were talking about Bhadra. Your Ellis goes away, and your trays are stuck. That is because of non-catching Ellis tissue syndrome. Happens everywhere, I think.
Yeah, it's a universal problem.
Okay. So usually vinculas are not so many in the gracilis. No. So we usually take the close-ended stripper, the smaller diameter one, and usually harvest is very easy. That is gracilis tendon. So I'll hand over these two tendons to Dr. Sunil. He will be preparing those tendons. Okay. Now let's go back to on, please. Light source on. To charge bani right? So light source, please. Anyone? Light source. Yes, yes. Okay. I hope the inside picture is visible.
Yeah, it's clear, Vivek.
Yeah. Nice, please. दस 15 आठ saver. Yes.
Vivek?
Saver blade. Yes, yes.
Vivek, is it possible to diagnose PCL injury by only diagnostic arthroscopy?
Diagnostic arthroscopy?
Yeah.
Yes, yes. Usually in chronic PCL here, what happens is the scar tissue of PCL heals back. Because of the anterior and posterior meniscofemoral ligament, the PCL tissue, unlike ACL, does not fall down. So usually in long run they heal, and it is not by probing of PCL tissue. It is actually by this sloppy ACL that we diagnose there is non-functioning PCL. Okay, I think I made myself clear.
Yeah.
So saver is not working. Again, another universal problem.
Vivek?
Yes, please.
Will you please highlight some of the tips and tricks to prevent the ACL injury during isolated PCL reconstruction?
So iatrogenic ACL injury, you mean, right?
Yeah.
Okay. So careful dissection is the key, I think. So this is ACL, this is slack, this is PCL, the remnant. Enter drawer, please. I'll ask my assistant, Dr. Rohit, to do enter drawer. By doing enter drawer, this goes to its normal position. So by doing this, also we can prevent the injury of the iatrogenic injury of ACL during the PCL reconstruction. So I think we'll try to preserve the remnants of PCL during this surgery. So this is in between the cruciate. This is ACL and this is PCL. See, the PCL is visible over there, and we will go in between this tissue. So we'll gently go on dissecting like this. RF, please. Okay, RF, okay. So this is in between cruciate. Bhadra.
Yes, Vivek, yes.
So
any advantage of releasing that intercruciate space?
It is easier, it is safer, I think. See, you can open up this posteromedial and posterolateral from here. See, wait, I'll show you. This is septum. Bhadra?
Vivek.
Are you with me? This is septum I'm reading.
Yes.
And this septum separates posteromedial from posterolateral compartment, right?
Okay.
So if we go right here and rotate our scope, this is posteromedial compartment and this is posterolateral compartment, okay? And intervening there is the septum, okay? And just in front of septum is that PCL remnant, okay?
Vivek, will you release all that septum from anterior side, or you go from posterior?
No, I'll release some and go and make the posteromedial and posterolateral portals.
Okay.
Needle, please. Byron. So we are going to make the posteromedial compartment. This is posteromedial compartment, and the bony anatomy that is seen is the rounded structure is medial femoral condyle. Lower part is the tibial plateau, and that is the posteromedial capsule. Check outside picture, please. So there are few techniques. There are some landmarks, and what I follow is outside birthday. So outside video is visible, right?
No, Vivek. No. Yes, right. Now visible.
Okay. So there are many landmarks. So what we follow in AKP center is we just palpate the soft spot right here, and from there we go in. Or what else we can do is we can just switch off all the lights and see the glow. I think some glow can be seen over here. Just over that glow, we'll go inside like this. Okay, this is the guide. Then from with 11 number knife, we'll go inside.
Can you show inside, Vivek, inside video now?
Inside video, please. Switch, Rajiv. So we are inside. Okay. The needle has gone inside and the knife has gone inside. So both of them will take out. Then we will.
Vivek.
Yes, sir.
So your inside point will be higher or lower or in the middle? Which one you will prefer?
Usually this is some soft tissue band. I tend to stay below that.
Fold, Vivek.
Ah, yes, I forgot that. I tend to remain below that. So this is dilator passed in. So cannula is very important in posteromedial and posterolateral portal. You know, it makes your life very easy. So our fellow Dr. Sunil is doing great job. He is inserting the cannula. I'll get the jog now, Sunil. Just be stable. Go in. Go in. Coming in, coming in, coming in, coming in. Few more rounds, Sunil. Few more. Okay, that's it. Remove cannula and dilator. So no cannula. Kissinger rod and dilator. See, this is okay. This is posterolateral compartment. Needle, please.
Hello.
Yes, Sanjeev.
Yes, Vivek, the nice demonstration is going, and I'd like to ask one question.
Please. My pleasure.
Once we have released transseptal from intercruciate approach, do you think just making one posterior middle would be suffice for doing PCL surgery?
I think that may suffice, but the anatomy, the wonderful anatomy that you see with two portals is irreplaceable. So I think I always, not only me, all of us in AKB center always make two portals, because by making only one portal, you are compromising. So why to compromise?
No, but we have released the septum anteriorly from transseptal approach also. We have released so much. So I think just making one.
Seeing from up and dissecting from down, there will be some parallax effect and all those effects. You are never anatomical. You will be lucky if you become anatomical. So I think all anatomical can be only done with two portals posteriorly. So that is the only answer. Otherwise, it is doable and many people do it.
I think, can I just add to that, Vivek?
Yes,
I think Sanjeev has a very valid point, but he's talking about if you release septum, then your popliteal artery goes back, the safety increases. But yes, the visibility is not good from anterior. So if you know that we have to go all the way down about 1.52 centimeter below the tibial plateau with that point. So particularly the champagne glass point is not visible from anterior, anteromedial or anterolateral. It is visible only from the anterolateral or anteromedial portal. So that is the reason we make both anteromedial and anterolateral. But I absolutely agree. Some people do using 70-degree scope. Some people do making a two anteromedial portal. But this is what we prefer. Anyone can, do with one portal as well. But I think, believe me, Sanjeev has seen us doing all the cases with both the portal. This is one of the most easiest and the safest. You can pass one Kissinger rod to retract your capsule posteriorly. So it has a lot of advantages. Vivek, you can continue. I think we have answered Sanjeev's question.
Well, thank you, sir.
Wait, something.
Look, you open panic.
Yeah, Bhadra, you were trying to ask some question?
Yes, sir. It's not a question, sir. It's just an experience. With 30 degree of lens, I think it is very, very difficult to do with one portal, sir. In my experience.
Okay.
So posterior lateral and posterior medial both are, I think, should be made, sir.
So what Sanjeev was mentioning was like this, seeing from anterior and dissecting from posterior, right, Sanjeev? So, but anatomy is never perfect with this. You are not pretty sure whether, see, you cannot see, as Amit sir had just mentioned, champagne glass, you can just guess, okay, we have raised the champagne glass, but we are never sure. So this is never anatomical, I think. So anatomical will be to change your scope to posteromedial portal like this. Oops. Like this. So see the anatomy, what you can see with this portal. See, this is PCL remnant. This type of anatomy is never visible with only that single portal. I think that is the thing, that is the reason why we do with two portals. Amit sir?
Absolutely agree. But again, agree with Sanjeev as well, you know, that you can do. There is no doubt. People used to do from all anterior without any posterior portals, you know, without any posteromedial and posterolateral. But once you start doing the transseptal, I don't know how you can think about doing a non-transseptal, you know, all posterior, 2 tunnel posteriorly, and you are so safe, you know. I think that is my approach, but it is doable. It is doable.
So this is the remnant of LPPO. Aurora, इसको off कर दो. Line off कर दो. So see, I am going down, deep down. This fronts of synovium is disturbing me, so I am removing them.
So Vivek, your scope is in anterolateral, and you are inserting your this RF ablator from anteromedial.
No, sir.
Posteromedial.
Scope is in anteromedial, posteromedial, and my RF is from posterolateral.
Okay.
Can we get the outside picture, Mr. Chet?
Okay. Can it be from the front side, Vivek, so that not from that side? Okay. Yes. This is beautiful. So your scope on the anteromedial and your
yes, sir.
RF from the anterolateral portal. Beautiful. Yes. Beautiful demonstration. Good.
So see, this is the the cannula at the posterolateral compartment, and this is lateral tibial, lateral condyle, and here you can find the lateral meniscus, and this is the remnant of PCL. So you just keep on dissecting. These are something which are disturbing us to get the anatomy. So we'll be just dissecting downward.
Vivek?
Yes, yes.
How downward or how inferiorly will you dissect?
So till I get that champagne glass drop off, I feel that.
Okay. Will you visualize the popliteus muscle?
Very rarely, very rarely. Sometimes you visualize, and sometimes another landmark is the shiny white fibers. So these are visible right over here. If I'm lucky, I'll show you. PCL lies just below that shiny white fibers. Oh.
Can you just, Vivek, can you just, you know, release a little bit, because many people, they talk about this shiny white fibers, which is indirect, you know,
So
landmark.
Should I see that shiny white fiber, sir?
Yeah. Yes, I can see there. Yes, beautiful.
Yes, yes. These are medial meniscus. From medial meniscus root, first you have to reach up to the medial meniscus root, and from there downwards, you can see just anterior to PCL remnant. I think we have to probe it like this, and some shiny white fibers will be seen here. I think we are not, I think these are.
But it's somewhere there, Vivek. I think it's...
please. I'll try to find.
Okay.
So these are the remnants of.
Yeah, just above. Yeah. That is it. Alimathi.
Yes.
Yes. Yeah, beautiful. Yeah, that is the shiny white fibers. You can see that.
These are the shiny white fibers.
Beautiful.
You know that we will be finding that thing. Arish, please. So you must spend a good amount of your time dissecting this posterior part, you know. It is really very challenging job and very risky job. If you dissect your posterior part very carefully and very nicely, your job later on is very, very easy. So I'm spending so much time in dissecting this posterior part. This posterior part, you should be very careful. Never point your cutting instrument posteriorly, because there is a monster, popliteal artery. If it's injured, it's gone. So I think, Badra, only you are asking
Vivek.
questions, Badra. I think.
Yes, Vivek, you have done a wonderful job, Vivek. It's a very nice dissection. Really wonderful.
Sanjeev, any questions?
Yes. I have one question, but it's not related to PCL, but it's related to PCL avulsion. When I was doing one case here in CMC, doing PCL avulsion, I had that avulsion part was going in the posterolateral part, and I had very difficulty in making posterolateral portal. Any tips regarding that?
Come again, Sanjeev.
I was doing one post PCL avulsion case, and that fragment was going into posterolateral compartment, and I had very difficult in making posterolateral portal. Any tips on that?
Okay. So I think in that while doing your PCL avulsion, you must always make the intercruciate approach, right? So from intercruciate approach, I think intercruciate approach, and by making one posterior lateral portal, one posterior portal, you can manipulate something. But sorry, Sanjeev, I think that is only way. Otherwise, it will be a difficult thing. How did you get through that problem? I would be.
Anyway, I managed to do that, but I was very struggling. It took me half an hour to make a posterolateral portal, but then it does not take so much the time. But I was very struggling at that point.
Okay.
Amit sir can highlight, can give some tips regarding that.
In those cases, you can do a railroad technique of making your posterolateral portal. So if you have made a posteromedial, then find out the septum, use a Wissenger rod.
Okay.
And with the Wissenger rod, you go to the posterolateral compartment and come out of the skin. Give a small nick on the lateral side and take out your Wissenger rod from the lateral side. So your Wissenger rod is going all the way from posteromedial and exiting into the posterolateral. Okay. So once you have done that, then pass your cannula over that Wissenger rod and gradually insert your scope. You'll be able to make the posterolateral portal as well.
Yeah, I think that is very nice thing.
It is not our stuff tip. This is described by Dr. Bancha Chiranjit, and he said is railroad technique of posterolateral. He doesn't make an outside in posterolateral tunnel. He always makes a inside out, the railroading posterolateral.
Thank you.
How are you? So it happens very often, you know, the cannula comes out. So I have, okay. So I think our dissection is done. That is champagne glass drop off. The curvature suddenly goes down. RF. From here, the alignment, the orientation has changed. I think that is I can feel that the champagne glass drop off is right here. So I'll make a point over here so that I'll come. Amit sir, is that point okay, sir?
Beautiful demonstration, Vivek.
Thank you, sir. We'll see from here as well. I think that is good point. There was the point of shiny white fibers just below. I think that will be good. Okay. PCLJ, please.
Can you show this transcruciate view of the same your dissection? It will be very interesting, and it just looks like
it's really tough thing. It is not visible, I think. So I think that also answers the Sanjeev questions. It is very difficult. Sanjeev, it is difficult.
Okay, point taken. That is what I wanted to make. You can do it, but the dissection from where exactly the beat pin is coming is all blind process. I think posterior lateral, posterior medial will make very clear.
Length here, quadruple length here. So we'll go from here, see, and keep our port scope in posterior lateral portal like this. This was our marking right here. Okay. So almost about 20, 15 to 20, we are down. I think that is good thing. So angle is very, very important in PCL surgery. We usually keep 60 to 65 in zig. I think you all are aware of this zig angle. Bullet, please. So the assistant who will be drilling in PCL surgery must be very, very good one, because it's very risky while drilling in PCL surgery. So Vivek, it must be controlled. Yes, sir.
Vivek.
Yes, yes.
From which portal are you seeing? Are you viewing this?
At present, I am viewing from posterolateral. See how while cleaning, I view from posterior medial and clean from posterolateral. And while doing this drilling, what happens is you tend to clean more at the portal where your cleaning device was, like the RF was. So the vision is very clear with this portal. So I usually change my portal site when this thing is used. Between change. So Bhadra,
yes, Vivek.
I answered your question, right?
Yeah, yes, Vivek, yes.
So here we are. There is some misfiring, but I think
yes, that is also a universal problem.
So this is I think we'll take it. Amit sir, we'll take it or we'll change it? Your call, sir.
I will take 100%.
Okay. Then I'll take it too, sir. So next thing, very, very important step, I will request all of colleagues to do it, is use this thing. Outside picture, please. Use this thing. This is called PCL catcher, and it increases your safety while drilling tremendously. Always use it. This is called PCL catcher. Always use it.
Vivek, can you just show the hole which catches the
there is a hole right there where the beach pin is taken, and this is completely blocked, completely closed there. So whatever you drill does not go out. So this is very, very important safety device. So you just go in just like here.
Inside, Vivek, inside, please.
Inside. Yes, enter drawer. Right. Inside. Okay, I've gone from intercruciate, change my scope to posterolateral again. See, this is the hole I was mentioning, right? So I'll ask my assistant Sunil to just hammer it. Wait. It has just, the hole has just gone there. Okay, that's it. See, it is now safe. You can drill. Size of graph, please. Quadruple 8. So we'll be drilling with 8. So by using this particular instrument, safety is very much guaranteed. Wait. See there. It has gone. Okay. Let's go. Here, right? See there. Always the system must see into that picture. Come. Between this wait. Between like top hammer. So this is also a universal problem. We tend to reuse the between, you know. Wait. Wait. Push. So what happens is bye. What happens is or no huh?
Vivek, I think you should try once again. I think this has misfired, you know.
Yes.
He has inadvertently pulled it out. I don't know why he pulled this bead pin out. While reaming that inside, the bead pin came out for some reason. So I think you have to redo it again because the hole was way down. This looks very up.
Between jig this. I'll do it again. Between direction change between so that is also enter drawer. Okay, logic. No. Sorry for this technical problem. This is also a universal problem, you know. We tend to use and reuse this bead pin, and this is what happens. The bead pin is bent and it is tightened, and this happens. So you have to be very careful while drilling the tibia in PCL. No. Baba, ठीक करो ना. It was already from me. Okay, that's it. That is bye. PCL catcher, please. I think now we are in place. It was way high. Enter door, please. Okay. Okay, come up. Okay. Now drill. Any questions in the meantime? Madra?
Vivek, this instrument is not available, then can we use that jig, PCL jig to block this big pin?
Not available.
Okay, if PCL catcher is not available, can we use PCL jig? Of course, we can use it, but this is the safer one. Try to get it.
Okay. Thank you.
Because safety is the most important, you know.
Yes, Vivek.
We can use that thing. We can use that thing, and in fact, we were using that thing, and what happens is the margin of error is very low with that thing. You have to be very careful. Your palpitation decreases with this instrument, you know. That's it. Otherwise, we can do it.
Vivek, what will be the position of your knee during drilling the tibial tunnel?
Position of tibia?
Position of knee, I mean, at what angle? 90 degree? 90 degree?
Position of knee is same. 90 degree.
Okay. Okay.
Vivek, can you show us how you reduce the killer curve by using chamfer rasp and how you use that?
Yes, sir. So that is a very important thing which I nearly missed. So the killer turn effect is very dynamic one, and killer turn effect not only occurs during graft passage, it occurs throughout the course of graft healing, and there are few techniques by which the killer turn can be decreased. The one I am showing right here is one of them. If the angle, the tunnel through which the graft passes is sharp, what happens is there will be more graft impingement and graft cutting. So try to rasp with this. And other few techniques are, there is some Fanelli point inferiorly and laterally. Try to make your tunnel more inferior and laterally, and drilling from anterolateral than anteromedial is also one of the described technique to decrease that thing, killer turn. So what we have been following is to increase the angle in that PCL jig and to rasp. That are the two things we have been following to decrease the killer turn effect. Amit sir, anything you would like to add?
Nothing to add, Vivek. I think you have perfectly answered.
Thank you, sir. Suture manipulator, please. Now, Sunil is passing the base pin loaded with the suture, that is ethibond, through the through the tibial tunnel. Once this tibial tunnel is made, what happens is water egresses out from there, and the visibility might decrease like this. Wait. I got it. So now thread has been passed. Now the tibial tunnel is made. I think you have to secure this tibial opening, otherwise there will be egress of fluid and everything will be that thing. So once the tibial that thing is made, now tibial tunnel is made. Now our attention is towards the femoral tunnel. So to make the femoral tunnel, you should know the anatomical landmark. So this is cartilage, margin of the cartilage. Usually there are, actually there are two bundles of PCL. One is anterolateral and next one is posteromedial. So anterolateral is the most important one and the widest one. And in single bundle PCL reconstruction, what we reconstruct is the anterolateral bundle. So this is the apex. See, this is the apex of the notch. And
Vivek, if you shave up this bulge over the PCL, then it will be very nicely visible.
We'll do it, sir. Doing it. Okay. I'll shave off some of these hats as well, because it will give problem. Okay. Pani, water. Okay, now the turn of bump. So that was abnormal bump, as Amit sir has rightly pointed. That was causing us difficulty knowing the anatomy. See this from here, the PCL anatomy is quite visible. PCL, the attachment of PCL, unlike ACL, is very, very broad. Can someone do the anterior drawer, please? Okay. So anterior drawer, ACL is tightened. So from here, right up to here is PCL. See, this is broad anatomy of broad femoral attachment of PCL. Whole of this is PCL. This is probe. So this is apex of notch, and here is the trochlear point. There will be some continuous line over there. This is the trochlear point, and trochlear point is the starting point from where the AL bundle starts. And from trochlear point to this medial arch point is the boundary of the anterolateral. And from medial arch point, there is straight line, the condyle goes straight down, and this is posterior point from where the posterior part begins. So from medial arch point to posterior arch point, posterior point is the site where PM bundle inserts. So usually AL bundle lies right adjacent to the cartilage, whereas PM bundle lies almost about 5 to 7 millimeter posterior to the cartilage, as shown here, as seen here, right? So this is AL bundle right adjacent to the cartilage, whereas this inferior bundle, that is PM bundle, is there almost about this. This probe makes almost about 5 millimeter. I think 5 to 7 millimeter. Center is about 7 to 8 millimeter posterior to the ACE. So what we will be reconstruction is this strong and more important, the AL1. So this is apex. This is cartilage ACE, trochlear point, medial arch point. So right somewhere here, I think. Okay. So this will be our point. Amit sir?
I absolutely agree. It has to be about 3 millimeter below the cartilage.
Yes.
And nowadays there is a trend to go much higher, than the
so you would like to go a little higher, sir?
Yeah, I'll just go little bit higher. Otherwise,
okay.
This is
this point, maybe this point.
Yeah, if you read Smijelski point, he said that it is right vertical, It has.
So I think this will be nice, right, sir? The second point.
This is nice, yeah.
Okay, done, sir. So change my portal again to the anteromedial. Then this is, may I get the outside view? So we do not usually, we usually do not have jig for drilling the femoral tunnel, What we use is, we use this femoral reamer as a guide, because see, we insert this here, and
so Vivek,
yes.
So which portal will you use for this?
So
which,
while marking, always see from the anterolateral portal and mark from the anteromedial portal. Okay, because you have to have direct vision of the that condyle, that particular condyle. But when drilling, you have to drill from the anterolateral portal. So viewing should be from the anteromedial.
Okay, so will you use far far anterior lateral portal or not?
Not really. While if I need to do ACL, I will use far anterolateral, otherwise no. So I'll make center of this point like this with the help of this reamer. So if it rotates like this, it does not cut the cartilage. Okay. Now drill, please.
Vivek, the size of size of your flower tip is same size of the graft, right?
Yes, sir.
And I will suggest you to keep this cutting edge, the maximum cutting edge towards the cartilage, you know, so
yes,
that you see that it is about few millimeter deep from the cartilage. You are absolutely on the spot.
Okay, sir, or you want some modification, adjustment?
On the spot, beautiful. I'll just rotate your flower tip little bit so that, yeah, so yeah, just wait, just a bit, yeah. A little more, yeah. So this shows that your cutting edge is maximum cutting edge is this one, and then it's beneath the cartilage. Perfect.
Yes, sir. Thank you. Oh, ये निकल.
Once your bead pin is in, you can just pull out your the guide so that you can see that this has acted as a guide for passage of the bead pin. See that? Beautiful, Vivek. Fantastic. Now you are using Indo button reamer?
Yes, sir. There is some problem with this. Yeah. This was not moving. That's why there was a problem. Okay, now I'm going to use the Indo button reamer. Indo button reamer, please. Okay. So be careful of patella, Rohit. Okay. Going. That's good. Through and through dealing with the endoscopic reamer. Okay. निकाल. Okay. Depth gauge, please. So this is depth gauge. We will be 40, 38, 36. So 36 millimeter is our size of tunnel. We'll be using 15 mm button. Okay. Within again. Now 8 millimeter. Careful with the patella, Rohit. Okay, looks nice. Go. 36, 31. Go. This is 30. Careful, Rohit. Little. Okay, great. Rohit is the most tedious, you know. He is the best driller. He reams the best. I am always confident when Rohit wins. Never over ream or under ream. I know, Bada. No. I think Sanjeev also agrees.
Absolutely, absolutely.
But we don't have 7.5 and 8.5 out here, you know. I know, Sanjeev.
Sakar?
What is the size of the graft?
8, sir.
Okay.
Quadruple, it is 8.
Length, what about the length, Vivek? What is the minimum length you require for PCL surgery?
Minimum, I think minimum 12.
Okay. So if less than that, then what will you do? Adjustable?
Can be done adjustable, but I don't think less than 12 is good enough. Adjustable can be done, but all inside PCL, we can get away with smaller length graft, but to fix with the interference screw in the tibial side, I think 11 or 12 is the must. Amit sir, any comments?
There are so many things, modifications, but most of the time, you can get away with 11, 12 mm graft. You'll get those 11, 12.
If the length of the graft is small, then would you change your fixation to adjustable loop? Eh?
Absolutely. It's not necessary to have adjustable loop. You can put a biodegradable screw, maybe interference screw on the femoral side, and then same in the tibial side as well.
Once. So we are almost at the end of the surgery. This is some bony points, bony prominences. So I'm cutting it out. Okay. Sakar, please.
Vivek,
Yes,
how will we decide? How will you decide about the femoral tunnel? Whether we have to do horizontal, oblique? Any tips for that?
Sorry, Badra, I didn't get you.
The direction of the tunnel.
So we usually prefer the oblique one because it increases the graft obliquity. Second, number two, it increases the length of the tunnel. So we usually drill in the oblique direction. So what I'm doing is I'm making the pathway for the future graft because of this remnant. There may be overstuffing of the graft. So though I made that thing intercruciate approach, but the graft will come from here. That will be more anatomical. So I'm making some pathway for the graft to stay in and overstuffing can be avoided. Okay, that's it, I think. Suture manipulator, please. Okay, I've gone just below the PCL. I will see from this portal that is posterolateral. Okay. Can you push? Okay. So just push. Not like that. Well, I feed Gaurav. I've cast it. Okay. Okay. Now this has come. I'll take this whole thing from the and to park it in anteromedial portal. Seeing from the anterolateral portal, now I will get both of these sutures from the same anterolateral portal. This is the suture from femoral tunnel, and this is the suture from the posterior tibial tunnel. So I think we have cast both the tails of the thing, and now both of them have come in this same soft tissue tunnel. So now we will reroute carefully. We'll shuttle this suture right from the femoral tunnel wala suture from the tibial tunnel. Okay. Okay. See there, it's going, and now it's gone. See, this is how the graph will pass. Now, is graph ready? Marking done. World's best marking. Okay. Wishing rod. So now there is another trick how we deliver our graph. That is called, we have been following since last few years, I think. So that is called the rod and pulley technique. So we pass our Wischinger rod and keep our thread, keep our thread posteriorly like this. Pass our Wischinger rod anterior to this thread. Now what we do is this threads will act as a rod pulley, and this Wischinger rod act like a rod. There will be sustained traction from our assistant, and he won't need to pull it so hard. Just our some manipulation will get that thing out. Previously, we needed to pull that graph so violently that sometimes thread used to break. And this is the rod and pulley I will be demonstrating shortly. So Rohit, please give us steady traction on white that thing, white suture. Okay, okay, okay. This is how we do rod and pulley. He will just give sustained traction.
Vivek, can you show it from outside so that people understand how it works?
See?
You are almost gone, but I think if you show the movement, how your Wischinger rod moves, and then
is it visible, sir?
Yes, beautiful.
So just by doing this type of movement, what happens? See, the graph goes in very easily. Rohit is not giving very little traction. He is giving. All of graph passage is being done by this Wischinger rod.
I think you can see it from interior. You have gone enough.
Okay, sir.
You see, you are almost there.
Yes, sir. I was carried away. Rohit, can you try to flip it? Flipped, right? Okay. So this is our new PCL. This is ACL now. By giving traction over this PCL, see, the ACL has tightened. See, it was like this, slack. And after doing PCL, this has. So final thing is we just have to put this screw and then done. Sag decoration. See, this is outside picture of sag. What? Okay, that's it. Now screw, please. Notice. Soft. No, right? No. So we are using 9x30 size bias screw. Not bias screw, it is. Chet, what is this screw? I forget. Bi-composite, sorry. It's a composite screw, bi-composite. So
Vivek, you will put the screw in the same position of the knee?
Yes, 90 degrees.
And you will give the anterior drawer, right?
Yes, I am giving anterior drawer outside this. I am giving anterior drawer. Sunil is doing the screwing work for me. So that is very gritting sound I am getting, and very okay. Go in. Still going. That's it.
What is the length of screw that you have used?
30.
So what do you think were the length of that tunnel?
Length of the tunnel?
Yeah.
I have not measured, buddy.
Okay. It would be they have some of the literature or some of the they have told that you have to use the length to the aperture, then it will be
Yes,
a good fixation. Do you think so?
Yes, some people, some surgeons think so. Some people, some surgeons say that you have to look from posteromedial or posterolateral portal and see the tip of that screw comes through there. That is one of the technique by which it is said that the that thing the kiloton is decreased. But we have been doing this and we are getting good results, so we are continuing with this. The problem with that technique, that thing is, Sanjeev, once you go through the cortical part of the anterior cortex, then there is whole cancellous part only. Okay, whole cancellous part, and cortical part you will be getting in the posterior cortex only. So, so if you do not get a good process with that cortical part, if you are not so lucky enough, their fixation will be not so much strong. I think that is the only thing we are seeing. We still continuing with this particular thing. See, the ACL has tightened enough. There is no slack ACL. Rather than palpating the PCL, I would palpate the ACL. This is good tension. PCL is also tight. The AL bundle has been reconstructed. I think that ends our surgery. Thank you so much. If any questions, you are most welcome.
Vivek,
yes.
Vivek, will you describe in brief about the post-op protocol?
Post-op protocol, very nice.
Yeah.
Post-op protocol. So see, post-op protocol in PCL surgery, there is a saying, and that still is valid till date, is go slow. You do not hurry as in ACL surgery. You do accelerated, but go slow. You use PTS brace. PTS brace is not available in our country. So use the brace and keep some pad over the area where there will be the cuff, and try to maintain it almost about 6 weeks. And give the quadriceps. Quadriceps should be strengthened more than the hamstring. Hamstring passively you compress, you give strengthening hamstring, the quadriceps to be strengthened more, because quadriceps will pull the tibia anteriorly. So hamstring, function of hamstring should be done very late, I think almost about 6 weeks. So quadriceps exercises, SLR, and gradual range of motion. Get good extension first. Flexion you will get, and use PTS. Okay. And if you are not confident enough, delay weight bearing. It does not matter. Delay weight bearing till you get good quadriceps control. Delay weight bearing. That's it. Any more?
I think Vivek, I just want to add on what Sanjeev was asking, the mismatch of the size of screw. The interference screw are known as the aperture fixators. So it has to be fixed at the aperture, not inside. And there are two aperture. One is on the anterior tibia, one is on the posterior tibia. So I think either you fix on the anterior tibia or you fix in the posterior tibia. Sometimes some people use two screws, they go with one screw, they go all the way to posterior, and then they put another screw on the anterior.
That ends our live PCL surgery demonstration. Thank you so much. Thank you, Amit sir. Thank you, Sunil. Thank you, Rohit. Thank you, Rajiv. Thank you, Yogi. Thank you, Rem, Chet, anesthesia team. Thank you so much.
Thank you, Vivek. That was excellent demonstration. Great job. Good job.
Thank you,
sir. Before we finish, I'd just like to announce that we have recently established the live telecast system at our AKB center. And this is today we have demonstrated 3 back-to-back live surgery. And hopefully from next time onward, with prior information, we will demonstrate all this live surgery. Thank you very much, everyone, for being with us.